are available on WhatsApp and WeChat, and you can email us on this super long email address, or just text Julie or me, and we can add you onto the social media groups and send you email invites. So please ensure you're muted at all times, except of course to ask a question or comment. And we have 10 to 15 minutes at the end of the talk for Q&A. Please use the reaction button to raise your hand, or use the chat box by writing your name. So we wish to know, we know you wish to ask a question, or that just type a question in the chat box and we'll try to get to as many of them as possible. And over to you, Dr. Karen.
Thank you very much, Rahul. Good afternoon, colleagues. I'm delighted to welcome you to this first nurse-led seminar in
Recording
Julie's
in progress.
amazing.
This meeting is being recorded.
In Julie's amazing Royal Hospital for Women webinars. Our speaker today is Dr. Dee August. Now, Dee is a colleague and a friend of mine that got her PhD just last year and is one of our leading experts in neonatal skin injury. She's a postdoctoral research fellow and has a diverse background in healthcare provision. She works at the University of Queensland, and I am delighted to hand over to her to take us through the past, present, and future of assessing, treating, and preventing neonatal skin injury. Dee, over to you, and thank you so much.
Thank you, Karen. Just make sure this all works. I'm just going to, so we have green means go.
Perfect.
Okay, great. Thank you, everybody. Thank you for the opportunity, Karen and Julie, and thank you for all of those who've been able to attend and join me today. I'm excited to talk to you about questions and comments after we finish. So as Karen said, I work for the University of Queensland and also here at the RBWH in Brisbane, Queensland, Australia. So we're today going to talk about the past, present and future, slightly different title, but same meaning, of assessing, managing, treating neonatal skin injuries. And we're going to talk about that in that lens that we talked about over time. So today I would like to begin with an acknowledgement of the traditional custodians of the land, both on which I was born, of the Costoladian Ohlone tribe of California, and the Turrbal people where I currently work and live. Pay my respects to elders past and present, and extend respect to Aboriginal and Torres Strait Islander people who might be joining us today. So just a bit of an overview so you understand how this is going to work. We're going to talk a little bit about my background as a healthcare clinician, because I think it helps change how we might think about some of the work I'm presenting and the care context, because I know many of you are joining from outside of Australia, so it's important that you understand the care that we provide here. We're going to look at skin structure and function across the past, present and future. We're also going to look at skin assessment, and then eventually we're going to touch on management and management treatments, both within the lens of the past, present and future. So believe it or not, I have been working in healthcare for almost 20 years, maybe 20 plus, but I'm going to pretend not to count those other years. And while most of people will look at the work and think that it represents is mostly neonatal care focused, I've actually had an amazing opportunity to provide a lot of different lenses within healthcare. So I've actually been a pediatric and a pediatric critical care nurse. I've worked in obstetrics and theatre in surgical capacity. I've worked for retrieval services in North Queensland, which has taught me so much about clinical context and care provision. I had the great opportunity to work for the National Standards Working Parties in Queensland bedside audits, specifically around pressure injuries, but we did audit lots of other things. I've got some background in skin cell development, or embryology as we call it, which is really important and vital to the work that I do. I, of course, finished my PhD and have a grad cert in research methods, and I actually am certified as a wound care nurse as well. So this isn't really about boasting my CV to you. It's about helping you understand why, when I came upon a clinical problem, I kept thinking that what we were doing wasn't good enough, and why it's really important to look at what we did in the past and say, how can we improve it in the future? And then I'm very fortunate to work in an amazing area in Australia, and I had the opportunity to work quite a bit in New Zealand for my PhD. So for those of you who aren't familiar, these are some stats from 2020 and 2021. Not perfect, but it helps you understand the population. Well, we're quite a big land mass. We've got a small number of people living on it compared to other places in the world. And a third of our healthcare that we provide in this setting is rural and remote. And I think that's really important as well. So it changes things. Interestingly enough, the 2020 stats I got around Australian labour was that most of it was happening in public hospitals, and some of it's happening in birth centres and home, but not a large portion. So we're seeing a lot of babies in the hospital who might be well and unwell as well. So the main thing we're focusing on today is skin. The most important thing to remember at the end of the day, that the skin is the largest organ of our body. It's a moving machine that does many things, and I think we often forget that. It's not just a barrier or a cover. It's a barrier, but it has three specific purposes of being a barrier. So it's a chemical barrier in that it actually has an acid mantle. And when that acid mantle doesn't work, it can't help us fight bacteria, which might be growing across the top of the surface of that. It's a physical barrier, which of course blocks diffusion of water and prevents things from falling out of the body. Imagine that. It keeps it all contained. And then of course it's a biological barrier in that it helps generate immune response. So if we have something settle onto the skin, it will fight against us, and especially in the presence of a wound or an injury, it actually has a macrophagic property in which it will fight against anything growing. It needs to help with thermoregulation, as we all know, being neonatal care clinicians. Plays a vital role in that, but it's also a receptor of touch, pain, and temperature. And so it's really important that we think not about this just being something that protects the baby, but something we interface with. And later in life, if the babies reach pediatrics and adulthood, it is expected to protect us from the sun. So it actually has a lot of jobs that it does every day, and I think sometimes we forget that. In the past, the way we thought about skin health is that if it had integrity, meaning it didn't have an injury or a break, that it was completely healthy and happy. And while I don't disagree with that, I think that's a very one-dimensional way of thinking about skin. Like I said, it's not just a layering, it's not just an orange peel that protects the things underneath. What we also saw in the 80s was a lot of traditional concepts around there are three fixed structures of skin, and that the most important of those was this top layer of the third layer, which is a stratum corneum. But the reason we thought that was because that's what we knew most about. So we actually had the most evidence around the stratum corneum. And we generally knew that neonatal skin was thinner and weaker, but we didn't really know what neonatal skin properties were. Between the 80s and the 90s, we also saw some early glimpses in histological research or lab-based research where they did take skin biopsies and measured them. And this histogram you would have seen in many textbooks and many guidelines. And it's a histogram of a 28-week baby on the far right bottom corner, a term baby in the middle, and an adult in the top. And I'm not going to spend a lot of time on this, but it's important to think about, well, we knew, again, it was thinner and the structure looked different. We didn't know what those functions were and how it functioned. And a lot of our opinion about skin health and skin structure was really descriptive and opinion-based rather than comparison-based of function. In the later early 2000s, what we saw was a big increase in the use of things called risk assessments or condition scores. And of course, the most famous would be the neonatal skin condition score. And this was conducted by Carol Lund and her colleagues, and an amazing body of work in which they built a giant guideline to help us care for baby skin. And it has become the foundations of what we do in neonatal care every day. It was quite a pragmatic tool, and that a perfect score of 3 meant the skin was perfectly healthy, and that the worst score of 9 meant that the skin had problems. But as we work in a field now that survival of 23-weekers and care of these patients is long, this tool probably doesn't fit all of the intentions that we need to do in order to assess skin health. At the same time of those early 2010s, we saw a lot of changes and increase in things called risk assessment scores. And again, I'm going to break some more hearts today because I'm not going to tell you which risk assessment score actually works for our population. What I actually will tell you is that there's quite extensive research coming out of it, adult literature and research, that risk assessment tools for pressure injuries actually don't work. They're one of many key elements that might, but there's actually quite high level evidence now saying they actually don't predict injury very well. So even adult tissue viability and skin experts are moving away from those tools as being the main thing they use, and it's part of a toolkit in thinking about skin problems. The other thing we started to see in 2013 and 2015 was some discussion around what we see. And that's what skin has always been. It's been something that a clinician or an experienced person looks at the baby or looks at a patient and says, there's something different here. There were some early images taken, but those tended to be more traditionally for things like litigation around, extravasation sites and things. And there was a lot of talk around pink might mean one thing and red means another, but that was all due to interpretation. So this is a starting point to my research career, was 2013 to 2015. So I started to really think about what did we know? How did we know it? And so I did something called a nomenclature analysis. And this was part of my PhD and is published if you're interested in it. So what I did was looked over 35 years to see what problems were we concerned about with skin from the literature. What did we call them? Were they all the same thing? and how long would we be concerned about them? Because surprisingly or not surprisingly, neonates are the most at risk hospitalized patient population for skin injury, and they have the highest prevalence, even compared to geriatrics and compared to oncology. So the nice thing was this diagram really brought home for me that neonatal clinicians and researchers have been concerned for 35 years about skin problems. It's just as time has changed and certain research topics have become more popular, we focus and rename things appropriately and sometimes inappropriately. So there's no take-home message from this other than we've known it's a problem and we tend to change the naming of that, whether that's with translation or just with culture, but we need to be careful about that. The other thing we did in the past, especially with neonates, because of the risk of absorption and because of all of the case studies we heard about babies getting burned or oils going on and causing problems, or babies absorbing things like cleaning solutions and causing problems, we started to take on this concept that we have to be cautious with anything we put on skin, and that dry is always the best thing. So we even took on the practices of airing things out or heating them to get the skin integrity better of a broken area. We kind of started to take on this concept that dressings are dangerous and that wound care specialists couldn't help us, and well, we didn't know what that did, so we were cautious in using it. And the main reason, like I said, was about the risk of absorption and further damage. So I support and understand the theory, but it meant we actually stepped away from a whole area of research and practice because we were concerned instead of exploring it. When we look back to a study done by McGuire in 1999, what we see is the products on the left that were used by nurses across the US in neonatal intensive care units. And this actually surveyed over 200 units. So it's quite a good survey. And what we saw was some of the products that they used for prevention and then the treatment. I do find it interesting that treating breakdown, it was suggested that they would use a gel mattress and an egg crate and a water mattress, but I'm suspecting that perhaps they're suggesting that they used it to prevent it from getting worse rather than actually what I would call active treatment of a wound bed. We see Tegaderm and Oxide and Aquaphor, which we still have in our arsenal, and Villagon is a moisture-based dressing, which I couldn't even find it on the market. I had to do some searching for, and Duoderm again is a pectin base. So we can talk more about those later, but things haven't changed much. There's nothing new and exciting that we really use outside of those yet. This is just a bit of a recap, and it helps to remind you on the timelines. So, in 2001, we have an international call out to say neonatal skin is at risk and is a problem, and we need to care for it carefully. In 2012, within the Australian context, we have a national movement to improve the way we care for all hospitalized skin. At exactly that same moment, with shifts in the US and North America in 2013, we have applications developed where you can, take a picture of an injury and help classify it and work with patients through technology. And in 2015, we also have international injury guidelines talking about how images are not just for litigation and are actually part of clinical assessment. And that was the moment that I think skin injury assessment, with my work and some other colleagues across the world's work, changed. And we really started to see a real change in how we thought about skin care and skin assessment. So I was lucky at the time that I was working and talking to colleagues across Australia, and I really did some good stakeholder conversations and surveyed practice, looked at some retrospective work like a nomenclature assessment we looked at, and we really started to think about things in new ways. So methods of skin injury assessment could include images as a point of data collection. And between 2015 and 2017, we undertook work led by the Townsville Hospital Neonatal Unit, along with Dunedin Unit and the Royal Brisbane, where I now work. And we did a multi-centre mixed method study, which has 7 publication outputs, some of which you'll see today in this presentation, which we explored skin injuries, both by the lens of clinicians and through prevalence. And then we looked at the outcomes of the images and quite a few other things. So I think you'll start to see a real change and shift in what I present now. One of the outcomes of that PhD, which was really integral, was I knew as a clinician and as a researcher that histogram I showed you a few slides ago was really important, but I knew it didn't tell the whole story. So what I did with a medical student who also happened to be a graphic designer, and I'm forever grateful for her, and one of my supervisors, was we went back through the scientific evidence and we did a unique review of the literature, and we identified the time points at which skin develops from the time that conception of 0 weeks of life to 40 weeks of life. And this was incredibly important because it changed the way we thought about neonatal skin. It wasn't 3 fixed structures. Some of those structures don't even exist while the patients we are looking after. And so I'll make a bit of a bigger slide so you can see what I'm talking about. So in this time point, what we identified was this light pink kind of grapefruit color that is closest to the teal, and that's called the periderm. And that was tucked away in a beautiful article back in 2010. And then that periderm sits on top of the fetus while it's in utero, and then it will break down and add to the vernix, which is formed. So when we have a baby that's born between 22 and 24 weeks, they're probably born without a layer that is supposed to exist to protect their skin. As that vernix gets thicker and then eventually dies down, the vernix is protecting the stratum corneum, which is the yellow color that you see on the far right, closer to the 40 weeks of age, which is the top layer of our skin as it grows. So even between 27 and 34 weeks, the stratum corneum has very few layers and it has very weak connection. So this starts to help us understand that while we do our best to prevent skin injuries, it is actually physiologically impossible sometimes because the skin is not intended to have friction or anything else in contact it with. And actually, it's supposed to have 2 additional layers to protect it until it's born at term age. And even when it's born at term age, those functional structures around protecting and staying connected are much weaker than they are in adults and older life. So this was the first time some of that important data was condensed. At the same time, or sort of a little bit earlier than that, in 2016, of course, Leslie Altamir conducted the work where she had the developmental care model. And this is really important because what she started to say was not only is the skin a function, but this is part of the care that we provide, is protecting this organ. That also kind of happened tandem at the same time that the national standards in many countries came out around promoting skin health for hospitalized patients. But I think we began to see the skin beyond an organ of function, and we began to realize that it was part of the health of the human. And we start to see it in a very different lens. So in present day, skin health is still determined by integrity. And what's the measure? So we have a measure, but it's still a bit categorical. So skin integrity is the absence of a problem, aka an injury or a break, which is measured by visual assessment. So it's measured by our eyeballs. Skin injury is by definition quite firm and concrete now. So we know it's damage to the epidermis, that top layer, or any of the underlying structures as a result of force or treatment complications. And we know often those treatment complications can be simple, meaning only by one problem, might just be moisture. But most often skin injuries are complex in that a mechanical force, pressure, friction, shear, stripping might be also related to moisture, or we might have nappy dermatitis in the same area we have friction. So there are lots of things. And at the bottom, we've got some common causes that we tend to categorize injuries into now. And all of these categorizations are only still identified by expert opinion in the present. So you can start to see how challenging this topic and field is because it really takes that expert, not only set of eyes, but decision-making around why things are caused and then thinking about treatment plans. In the present, we've also had some incredible work, not just by myself, but other colleagues across the world, which is identifying, again, the fact that neonates are the most at risk for skin injuries of all hospital populations. Clinicians are aware and know that most of the cause of that is specific medical devices, and we've actually done a really good job at preventing some of those, because when we did our multi-center prevalence study, we actually found respiratory interfaces, also known as CPAP, was actually the 3rd most common cause. So as a specialty, we've focused on that for a while, and we've started to put some good prevention strategies into place, but they're all not preventable yet. But it's the medical adhesives and our vascular access devices, such as peripheral catheters or central lines, that are our biggest problem. We also looked at the anatomical locations where injuries occur, because a lot of the publications that talk about neonatal skin injuries back in the early 2000s really talk about the back of the head being the biggest problem because it's the heaviest. But those are really term babies that are looked after in PICUs that don't flip and rotate positions and that are on ECMO and things like that. So we actually, again, proved that the anatomical regions for the true neonatal population actually are quite diverse. And we again looked at, were those devices fixed in place, meaning a breathing tube that needs to remain there and can't be adjusted, or were they things that needed to be movable? And you can see most of our injuries come from something that has to stay there. So this concept that they use in adult and peds of offsetting or offloading the pressure doesn't apply to this population. So it meant we need to start leading the research. We can't just copy and paste off the adults and the pediatrics. So I continue to pile on problems, don't I? It's not very fun. Risk for injury is greater than adults, but we don't have a lot of unique population-based research. We know that prevention is difficult because we have an organ that's underdeveloped and underprepared for the things we need to do to it. We know that currently we're comparing practice based on visual assessment, but even that's not being done the same. So I'm going to skip to the next slide, which is really talking about how you might think about skin injuries in your unit. And it's really important that when you go about doing this as a facility-based reporting system, or even a state or a national, that you have consistency in the way you do it. Because some people think red and pink is okay, but that's actually the beginning stage of an injury. And some units or research projects will classify nasal injuries different than the injuries across the rest of the body. And what's most important is that people who look after babies, we try and be consistent with this, so that when we're looking at places that might have practice improvement things such as CPAP bundles, or we might have a dressing that really works, that we're all measuring by the same thing, so that we know that it's preventing both early injuries and the severe ones. And if anyone has questions about these severity scales and classification systems, I'm happy to answer them at the end, but they really truly are just descriptive ways of categorizing things, and still slightly subjective from my science brain, but they're the gold standard that we have now. Those are the references. So I decided that I wanted to do something even more like a higher level of consistency for my PhD. So what we did was we developed something called the metric graduated color tool. And this is a series of images that are used in commercial photography for example, models or shoots. And it's actually been used sometimes in biology. And what it helps to do is helps to write a metric reference in the image, but it also helps to provide a reference for the color of the healthy skin and the injury, so that you have some contextualization around, well, that looks purple to me, but compared to that plethoric skin, is it really purple? And color-based decision-making is how we make most of our decisions in wound care. So not only does it help for consistency of tracking an injury in practice, but it also helps an expert like me look at that from afar and decide, is that really a skin injury, or what kind of skin injury could that be? Now, the other benefit of it is it helps zooming in so that you don't have to take a perfect picture. An example, sometimes we accidentally leave phototherapy on, and it lets me go into Adobe Photoshop and clean things later. So I'm a researcher who does pragmatic research. It's really important that clinicians don't spend 7 hours collecting an image at the bedside. So as you can see, I think that currently we're doing some good things around pragmatic skin injury understanding and practice, but I think we can still do better. So currently management, like I said, is based on expert opinion, but there are not enough wound care specialists who are also neonatal trained in the world. So most of the time, the way you make a decision around the dressings and the way we treat wounds is by guidelines. The most famous is the A1 guideline and most well known, and that's due for an update. So it probably is becoming out of date. Some of the colleagues and I are working with updating the World of Wounds from La Trobe's dressing care categories. But again, these are built for adults and pediatrics and not built for neonates. So some of the dressings and suggestions on these guidelines are not helpful. But of course, doing that is not exactly perfect, because it means you have to have the piece of paper or the book in the place that you need to treat with the baby in the middle of the night that has the broken head. So I think this is an okay solution for now, and making these common knowledge of ones that exist, but as we all know, they also become out of date. So keeping these up to date is challenging. So at present, we're moving towards what we're going to do in the future. To be fair, we're a little bit behind in between the adult and pediatric world, and we need to lead our own way. So we can't just rely on the adults and pediatrics to think about treatment as well as prevention and assessment. We need to move away from this concept of injury means one color, and we need to start thinking about complex presentations of injuries in practice and start categorizing them in the same way. And while you definitely can train staff members in adult wound training who have neonatal clinical experience and learn, it takes a long time. So we are working on something that's a solution. The other thing that's shifting as well is, remember the early slide about the past talked about a dry wound bed being good, or let's dry it out and get a dressing to help it become dry. That's very different than the current and the future treatment, is that we know that moisture is actually really important. And so a moist wound bed or a perfectly moist wound bed is actually what we want to see. And the way you make decisions about an injury management plan is that dance between too dry and wet and what's perfectly moist. And so actually dressing regimes should most likely be multi-phased in that you change the dressing regime based on the wound presentation over time. So again, I would love to be able to send you one slide of all the dressings you should use for each of the wounds, but it's not quite that simple. It is about treating the injury you see in front of you, with also taking in the lens of what caused the injury. So if a chemical was involved, we think of it differently than if it was a friction-related injury. So this is sort of where we're at. It is a science in some ways because you have to have the knowledge and clinical experience, but it is a bit of an art as well, and not two wound nurses will usually do the same thing because their clinical empirical experience leads them to think that some of the dressing regimes work better. We don't have good value RCTs around which dressings work best to heal wounds, and we don't even really know how long wounds take to heal in babies. So we've got a lot of work to do. What I can suggest for you is you can continue to use the guidelines that exist, but there are some resources which I think, yes, we have produced specifically for tape, and other things like this are coming. And while tape won't fix an injury, knowing how to use tape appropriately will prevent one. So this is a project that I worked on with colleagues from across Queensland, and we tried to look into all the different kinds of adhesive we use in babies, which we use a lot. They're all built for adults and pediatrics. None of them are designed for our fragile skin, to be fair. And we try to categorize them to help clinicians know at the bedside which things I'm using and how to take them off properly. But in addition to that, how to put them on in the first place properly. We can't tell you which tapes you should be using because that's a really complex thing depending on where you provide care. But what we can tell you is when you learn what kind of tapes you're using, you can start to make some better decisions on which tapes to use for which purpose. So in addition to a poster resource, which is now available both in the publication and on the Australian College of Neonatal Nurses website, you also can watch some YouTube videos around tape removal for each tape type. I think that's all I wanted to say there. So where are we going to in the future? The nice thing is we are going to the direction that I dream we might one day be happening, and we might be looking at not only the future of injury identification and assessment, but also how these impact on our patients. So we've just finished recruiting and doing the follow-up for a feasibility study. And that's with these amazing colleagues on the screen. So we have pediatric and adult tissue viability specialists. We've got a pediatric surgeon, quite a few neonatal nurses, a health economist, and quite a few nursing researchers. And the future of assessment and technology to assess severity and how bad a skin injury is really exciting. So I'm going to give you a little glance at that. So this is a world first comparison and assessment of 3 technologies for injury measurement. So compared to the gold standard on the left, which is a clinical image or an expert identification of one, compared to a pH meter, a 3D app, and a laser speckle or an infrared camera. So 3D wound imaging has been around for about 10 years. Often they can quickly calculate surface area and color distinctions. It definitely has some good potential in perimeter, but we're not sure if it can estimate depth. It's suggested it could, but of course the adult injuries like you see in the picture there are very different depth than ours. So it is a feasibility study to see whether this worked or not. And this is the first time that the app's been used in this population. We also are doing some surface pH measuring. Now, we talked about the acid mantle as a function of the skin, which is incredibly important. So this actually just tests the level of that acidity on the skin. It's been used in some early dermatitis studies in the 1990s and 2000 in babies, but this is the first time it's been looked at with mechanical force skin injuries. But of course, as we designed it, at the exact same time, the adult wound specialists have gone, that might make a good idea. And so it actually is becoming a research topic in adult pressure injuries as well. This is a point of care machine, so very simple to use at the bedside, versus the technology on the phone obviously has its own innate things. And the last piece of the machine is not a laser speckle, but we learned a laser. We learned this early, so it's really important to think about the words you use for parents. First 3 parents all thought we were going to laser the baby and, you know, cut them through like Austin Powers. But actually what it is an infrared light camera, which is very similar to the infrared light we use on a SATS probe. The picture on the far left is not a baby, it's a doll, just to help us talk about the distance that we needed to use between the baby, and any babies that had this measurement taken had protective eyewear on them, not because the infrared light is dangerous to them, but just for comfort. So you can see they're using the infrared and trying to obtain the perfusion-based measure of this injury for this study. And like I said, we looked at both the costing of this, but we also then talked to parents. So we use a validated burn scar profile with parent caregivers and the children of the injury at a 6-month time point to find out what was the impact to the parents about this injury as well. And for those babies we had the lucky to follow up, we also tried to ultrasound them, which is one that is actually becoming more common, not just in burn injuries in pediatrics, but ultrasound as a measure of skin assessment and health is actually becoming proposed in the skin research in neonates. But I have some challenges around that. We can talk about that later. So the third thing I think that's coming, but it's going to take a lot of funding and a lot more collaboration, is skin injury treatment and management using decision-making tools. So of course, decision-making tools we're all used to know being called an algorithm, which we used to do on paper, and now clever people are trying to put them into apps. So this is a app that was conducted by some colleagues in US, and it helps adult wound nurses, again, think about the type of injury or wound it might be and pick the best type of dressing or plan. But again, that kind of assumes that clinicians know what a necrotic wound is, what an infected wound is, and what a clean wound is. And I think sometimes we need to think and refocus how much energy and time we spend as neonatal clinicians knowing those things. I think we're starting to see a really exciting trend in decrease in the management of moments and thinking about treatment trajectories as well. So, like I said, I don't think one dressing will fix all injuries and wounds at all time points, but I think we're starting to think about how can we see consistency of injury trajectory. So how could we treat extravasations, for example, with a wound care package that might have 3 elements? And how could we treat a mechanical force injury with one pathway? So I think we need to move away from the expert opinion a little bit, but that's going to take a lot of time and a lot of collaboration and probably some testing as well. So a solution built in that same thought is, in the future, we really need some professional alliances, both from individual clinicians, but also organizations. So the Australian College of Neonatal Nurses has a special interest group in natal skin. We have 5 committee members, but we do have open and closed meetings. And there's a QR code link to our information sheet there. There's also some work being done interdisciplinary with a colleague of mine from New South Wales, who's a neonatologist and quite interested in improving this space. So our emails are there if you're interested in working with either of us on future projects. So that's all I've prepared today, but I realize I've gone quite quickly and I did want to leave some good time for discussion and questions. So I'm going to stop sharing now and see.
Thank you, Dee. Thank you very much. Thank you. We have lots of time for questions here, and I think this is a great topic, and we have lots of people on. So please put your questions in the chat, or if you raise your hand, I will come to you if I can find you, and we'll have some questions. While Dee's waiting, I'll just want to thank Julie for letting Professor Miki Konishi and myself from the Council of International Neonatal Nurses add a multidisciplinary aspect to your webinars. And so I'm the current president of COIN, and Miki's one of our directors from Japan. And I welcome all our Japanese colleagues that I see having joined today. And Dee's one of our research committee members. And each month we're going to bring some of the nurses from around the world to talk about what they're doing. Our next presentation will be from another COIN board member working in a humanitarian settings. So questions for Dee, please. I know that neonatal nurses talk about, and neonatologists all talk about skincare all the time. It's one of our greatest challenges in our tiny, tiny preterm babies, even to our big term babies. Dee, your experiences with the tiny preterm babies and skincare, thoughts on that?
Thanks, Karen. So I think the biggest thing is that that population probably, we have to remember, doesn't have a top layer of skin. So they probably actually don't have a stratum corneum, or if they do, it's singular cellular layer. So that's probably why we're seeing so many traumatic skin injuries on limbs. such as arms and legs and things like that. While they are superficial and they're red, I suspect that they are still a stage 1, if not a stage 2. And this is the challenge of visual assessment, is that they're probably a deeper injury than we can measure at the moment. Remembering that neonatal skin at most at term is only 1.2 millimeters thick. So when we go down to extremely low birth weight babies, it would be much smaller than that. Caring for them, there's no great evidence yet. It would be expert opinion, Karen. So I think we would be wise, and I'm hoping in my postdoctoral work to start working with some of the tissue viability experts that deal with very fragile geriatric skin and coming up with some care bundles that would be safe for babies, because I think we need to think about the leads we're placing on them and the traction on the skin from things like that, whether we need leadless monitoring. We need to think about the bedding that they're sitting in. And I think we need to think about providing comfort to the injuries that do exist. So the idea of applying really gentle silicons to superficial injuries to both prevent any transepidermal water loss, but also maybe prevent some of the friction from other things adding to that injury and making it more severe. We also need to think really carefully about bathing and how often we wash these babies and what we wash them in, because their absorption is exponential. And what we know from bathing in term babies is it actually doesn't really help skin health. It's a bonding environment. And so babies really only need to be bathed a couple of times a week. It's the parents that want the bathing, and it's a routine for children to have before bed. So we need to think about that. Moisture is definitely something that we need to think about for all of our babies. And there are some, of course, early studies being done by Tobias Strunk from Perth and his team, which are really exciting to see if rather than a commercial-based emollient, could we potentially use some oils. So this is an incredible space. We're going to see a lot of change in the next decade. It's probably a little bit on the back foot. We probably need it now. But I think it's the challenge of having the knowledge of choosing the right thing. So the safest dressings that we know are silicone-based. None of them are made for babies. They're all made for adults and geriatrics. They're quite expensive. Silicone tapes are not a silicone dressing, so we just need to be careful with that. But what you could think about is, how can I use an adult dressing that's already on impress in my hospital for geriatric patients and trim it down to fit a baby? And work with your local wound care team on that. So start to connect with those wound care and tissue viability nurses. You'd be surprised at some of the things that we did. I know in Townsville we used one that was meant for adult elbows, and that became our knee pad as we trimmed it down to a third of the size. So it's about being practical, finding resources you already have, but there are no dressings and wound care products that are really built for babies. And even if they are, they're not different than the products that currently exist. So we have a lot of work to do in that space.
Thank you. I see one question in the chat from Joseph. Hi, Joseph. Thank you, Dee, for a lovely talk. He's got a question regarding coconut oil as a moisturizer to prevent skin injury. And I know Tobias is online as well, so perhaps he'll come in on this as well.
Yeah, I would be more confident with Tobias answering that. I haven't had any practice with that, but what we know from the early studies is that coconut oil compared to other oils is a safe oil to use, and Tobias's study will, of course, provide other data around why it's safe. We know that things like mustard seed oil and sunflower oil are not safe, so we need to be cautious with the oils that we choose. And we need to also remember that the coconut oils that are being used in the trials are processed. They're not being bought off the commercial grocery shelf. So that is the organic ones. These are not ones you can buy off, and can bring home from the kitchen. So we need to do more work around what is the processing of those coconut oils to be safe for this population.
Great. Tobias, did you want to come in on this?
Yeah, thank you. Thanks for the question. We obviously have done some work on this, and the trial that we did a few years ago now, and the publications are available online. That showed that using the neonatal skin condition score, we were very grateful to have, at least some objective tool with good inter and intra-individual validity to measure the effect of this intervention on skin injury and skin condition. It showed quite compellingly that the skin condition did not deteriorate from birth, as we typically observe in babies that don't routinely were treated with topical coconut oil. We have since then introduced this into our routine care and now have treated over 1,000 babies with very positive experience. That's not to say that we never see skin injuries anymore, especially in the extremely preterm babies. Skin injury still does occur. There's still traumatic incidences. We still occasionally see pressure injuries from CPAP and other devices. And sometimes there are traumatic deliveries, especially in those very early gestation babies. But overall, there is a clear benefit on skin condition. And I think also what's new is that we've had a good eye on safety. And so far, we have only seen positive effects, and we don't have any concerns regarding safety. But I would like to take your point that you mentioned last, and that is very important about the product choice. And I agree, the coconut oils on the market are quite variable in quality and in the content of the biologically active components. So it will be important to provide a high quality product for medical use in the future.
Thanks, Tobias. The other thing that Tobias has mentioned, which is really important, and I think I elicited to it with the tapes, is we need to learn the products that we currently put on the patients. So, for example, we need to learn about the tapes that we use and what kind of tapes they are so we can make best choices for babies. Just like with the emollients that you use or the lotions you use in your hospital, you need to read the ingredients. You'd be surprised how many aqueous creams on the market also contain peanut oil. And while I don't suspect that's a problem for a baby while they're in hospital, if they have a history of allergy or atopic dermatitis, that can cause a huge problem for that family later. So we need to know what we're putting on. Skincare is not a soft science. It is becoming something that is important to be knowledgeable about, just like the medication we put in their veins.
Thanks, Dee. And I've got another question from Abchat. Any relationship observed with skin wound healing or complications with skin flora in extreme preterm infants in early days?
Thank you. Really interesting question. So we don't have a lot of good evidence around skin flora in skin injury compared to healthy injury. There is some work done on the microbiome of skin related to birth delivery. But again, that work is all quite early. So this is an evolving space. We don't have a consistent way of practicing of swabbing skin in babies. We might have it in practice, but we don't really have it from a consistency and benchmark point of view. And some wound experts will suggest that you need to clean a wound before you then swab it because you don't want the normal flora affecting it. So it's something that we need to work on as a specialty to be able to understand.
If I could add a couple of sentences, if that's okay. It is very important that we also consider what oil we use with regards to that effect on the microbiome. The skin microbiome, especially in the preterm infant, is not particularly well studied. And the importance of the effect of the emollient that is put on extremely preterm infant screen has been highlighted in one of the earlier trials. I think it was published in 2004 by the Vermont-Oxford network that did a clinical trial on emollients. And they did show using a mineral oil-derived emollient that while it improved skin condition, it actually increased the risk of sepsis, especially in the tiny babies. So just improving skin condition alone may not be enough to reduce the associated risk for sepsis, which is one area that our group is focused on particularly. So it is really important to evaluate what different emollients can do to the resident flora. And we have some data coming out that demonstrates, for example, that coconut oil promotes the common commensals on the skin, and there's less prevalence of pathogens on skins that receive this treatment. So that's, may add an important bit of information to our understanding of how emollients work and what we should be targeting.
Thanks, Tobias. And again, your comments have made me think of something else. I think the other thing that is challenging, which is one of the reasons of things like the time set of the neonatal skin condition score is that this idea that dry skin is good. So we're not just talking about cracked and dry scabs, that this concept I often hear in practice about, oh, that baby's much more mature because their skin is now dry. And actually, we don't really know what healthy skin should look like. And it actually is intended to stay in a moisture-based environment covered by a thick coat of goo by vernix for its entire thing. So the idea that skin becomes healthier and normaler as it becomes dry is still, by tissue viability experts, not considered healthy. So that's why we think we need to add emollients or oils to the top of it. And while it's important that we say, yes, it's appropriately dry, actually, I worry that by having that as a marker, it actually needs to be appropriately moist in because these are preterm babies. So we actually probably should see a gentleness and a suppleness to that skin for much longer than perhaps we are seeing, because of the way that humidity and the heat of the incubator may impact on those skin layers. So I think that all has something to do with that. Karen, I see a question there about, lots of questions.
A lot of questions coming. Might start with Rajiv. Rajiv's talking about, in his knowledge, allergists advise against using coconut oil for massage in newborns as it could sensitive to later coconut food allergy.
That's a really interesting point that so I do speak to some allergens regularly, or allergy specialists regularly, and we talk about this challenge around food-based products, but of course we know that all commercial-based products are not necessarily good either. So I think what's important, but I haven't seen the recent protocol, is that when we're considering whether we use a food-based product on a patient, that we ask about family history of all inflammatory diseases, so not just eczema or skin condition, but also asthma, because those three things are linked and often linked to food-based allergies. So again, each unit, each study has its own decision to make around that, but that's what the allergens recommend. And I look forward to the studies where we look at the long-term effects of things like coconut oils, because if it is the solution, which a lot of the preliminary data is suggesting, then it will be much simpler for all of us. But you're right, there are families that we need to study specifically and understand that relationship.
Great. And the next question is a question that Dee and I have talked an awful lot about. It seems to be a common problem in all our neonatal units. A question from Jill in Canterbury. What would you use on an excoriated bottom?
Thank you. So I think I'm going to give you the things I wouldn't do and lead you to making some decisions about what you can do locally. So all nappy-based creams are not created equal. What you can get in your practice, it might be unique. We have to understand that some excoriation and nappy dermatitis is normal for patients that you put a nappy on who have underdeveloped skin that you then stick in a hot box. So we're not going to be able to prevent everything. And we have the highest risk population because not only are they nappy-ized their whole life, but they're also in the hospital and on antibiotics. So we've got the core population. I think one of the most important things to do about treatment is identification. And so you need to teach your staff about what's a yeast-based nappy problem and what's a friction or injury-based from the feces and the urine. And that goes back to simply looking at pictures and looking at diagrams of what things are. Because if we try and treat nappy dermatitis, which has an underlying yeast, we're actually going to make things worse. So we have to treat the yeast first, and that means people need to know how to identify it. You can also look at things like what is the nappy we're using in the product. And the things I wouldn't do would be to put it under a heater. I do like airing it out, but that's not using oxygen or air from the wall. And this has to do with the skin needs a rest. And this is an old wound care concept in that skin doesn't do very well when we put things on it continuously and suffocate it, especially when it's irritated. So it was this idea that I kind of created when I was practicing more, and it was nappy free time. So if you think about how long a baby lives in a nappy in a neonatal care, it's a long time, and we don't give that area much break to breathe. And as wound care nurses, we know we need moments of wound dressing free time for the skin to be healthy and return to whatever its homeostasis is and in its phase of healing. So the biggest thing I can say is that you need to pick a consistent plan for each baby that has nappy dermatitis. You need a team meeting so that the medical and nursing team are all on the same plan, and that the caregivers at the bed are on the same plan as the leaders. The more you chop and change that, the more you will break the skin down and irritate it. You need to identify if there's another cause, like a yeast. And then you need to think about consistency of delivery with the parents. And I actually find often when I involve the parents in the nappy regime plan, they kept us stuck to the same page. And if things are getting worse in 2 days, then you need to reassess. But you need to stick to the same plan for 2 to 3 days to see if it's working, and give that kid some time without its nappy. That might be messy. It might mean that you have to change the nappy a few more times, but it actually works really brilliantly. And cleaning and drying that bum before you put anything else on it. So, not avoiding cleaning it. You need to clean it down to its core so that it has gently, so that it has some time for that skin to breathe again and get rid of some of that bacteria, because the poo and the wee combined together are actually causing the problem. So that is not a one-step solution, but that are some really key strategies in improving things. And parents will help keep you consistent and say, no, we want to stick with this plan for 2 days, and then we'll change it on Thursday if it's not getting any better. And remember that dermatitis presents itself in open and broken areas, as well as closed areas. So the way you treat the intact area that's red compared to the broken area that may be bleeding is slightly different. So what you put all over in an early stage of dermatitis might work, but if you've got red spots that are bleeding, that's not going to work there and not going to stick. But if you can get the rest of the skin healthy, you may then be able to treat the broken areas very quickly.
Thank you.
Thanks very much.
Thanks, Jill. And another question from Suresh: does prophylactic application of breast milk over nappy area has any role in preventing, minimizing the rash? Another topic that Dee and I have been speaking about.
Very interesting question. I'm guessing that you were listening to a conversation I had yesterday morning at 6 a.m. So I'm currently talking to some colleagues in the US. A name that you should look up if you're interested in nappy dermatitis, Media Esser. She is a postdoc nurse researcher and wound care nurse, so very exciting to work with her. And she said, I think there's 2 studies done on the role of breast milk in nappy dermatitis, but they're small. She's currently looking at building a larger trial. So we don't know yet, really, is the question. So watch this space and see what happens.
Great, thank you. Any other questions for Dee? I think every unit works on their guidelines on nappy dermatitis, don't they? And you get certainly the Skin S special interest group gets asked lots of questions about this. What's the best cream? What's the best type of nappies as well? Tobias, over to you.
Yes, I have a question for Dee, and I just wanted to get your take on how we should deal with incubator humidity and the interplay between applying emollients and regulating humidity. Clearly, I agree with you that drying out the skin may cause more harm than benefit. And one of the previous approaches was to regulate the skin moisture by regulating incubator humidity, but clearly there's a fine line between giving enough humidity and having rain out, and probably increasing the risk of colonization with pathogens, especially with Candida, who seem to enjoy a moist environment. So what are your thoughts on that?
Look, that's a really good question, Tobias. What was interesting is we did do some secondary analysis with my data set, again, from 3 sites that included some extremely low birth weight babies. And we found that humidification didn't have an impact on that study population. So it wasn't found to be a statistically significant variable. So I think it's important that some work has been done on it. There was a study done in Japan that suggested that it might have been had a role in skin injury, but in the more recent work, it didn't. That doesn't mean that humidity doesn't have any role in skin injuries, but it's just whether it had an overarching role in the prevalence at the time. I think it's also important to remember that what we know about transepidermal water loss and the population that was studied on is different than the ones we're worried about now. So the number of babies that we're seeing in the gestational age groups is slightly large. We're seeing smaller babies in slightly bigger numbers. And so I don't know that we have the evidence yet. I am working off the concept that we need a moist womb bed. I do think we need humidification. I'm not sure for how long. And I don't know that all babies need the same. But I know for safety and pragmatics of running a unit and making sure that we provide good, consistent care for measuring outcomes. But I would say that understanding this topic is not too far in the near future, and watch this space.
No, we don't really have a good measure to decide what humidity is right for the individual baby. It's really done by experience and gut feelings.
Yeah, so when we're looking at transepidermal water loss as a measure, which is actually the original intent of humidification, it actually wasn't intended to improve skin integrity. And from both the lab-based studies and some of the clinical studies we've got, we show that it doesn't have a huge effect on that. So it is improved to improve transepidermal water loss, which is a measure of skin health, I guess, and then of course improve all the other clinical things like fluid retention, hyperthermia, hypothermia, and all sodium retention, etc. So TOOL is one way of understanding the skin, and the way I like to explain this to people is that skin health is currently measured by visual assessment and sometimes TOOL, but we don't regularly measure TOOL in practice. It's a research-based thing, but there's lots of different ways in which we measure it. So another thing while we're talking about transepidermal water loss is a fun fact. When you remove a piece of tape from a baby once, you have a measurable change in TOOL. And this is on a term baby. So it actually changes the transepidermal water loss and increases it. And that's after one tape removal on a term baby. So, and that's without any change to the visual assessment of the area where you've removed the tape. It takes 10 removals on an adult in the same area of tape to even begin to have a TOOL change. So you're right, this has a huge place in the care that we provide. I just don't think we have the evidence to know what's the right recipe, but they're definitely related. And I guess I'd be asking you, are you thinking of doing a subset within COCO trial around TOOL?
Well, it's interesting because in the countries where application of emollients for neonatal skincare is most common in the Southeast Asian countries, and they obviously use a variety of oils, including coconut oil, but not exclusively, depending on availability. The reduction of transepidermal water loss was one of the tools that was used to assess efficacy of the intervention in those trials, and has shown quite distinctly that in a baby nursed outside the incubator, application of an emollient a couple of times a day distinctly reduces transepidermal water loss. In addition, it's in those areas where intrauterine growth restriction and unavailability of formula always is also a problem. It contributes to better growth because there is some uptake of fatty acids through the skin. So there are some very interesting points that come out of those trials. And regarding skin injury, for those that are already routinely using an emollient, one of the downsides, the very limited downsides, and it's more an adaptation of how we care for our babies, is that, of course, if coconut oil, for example, is applied too close to adhesive leads or tapes, it will get into it and start removing it. But while we try to avoid that most of the time, you can also use that effect to your advantage and, in fact, use some of the oil and apply it onto the tape purposefully to remove it, because it really softens very well and it slides off very easily.
Some units do use oil regularly, some units use adhesive removers, and that's actually part of those educational resources that we have on the adhesive remove and the Marzi. So we do encourage use of a moistening agent to release tapes. You're 100% right. It's just the evidence we have around whether it reduces the events of Marzi is yet to come. So it does have a role. It's just, I guess, I think of this tool as one way of thinking about skin health. And you're right, it is very related, but it's not the only measure.
We have 1 minute left, and Mark Broom's got her hand up. Mark, very quick question for you.
Hi, Dee. Fabulous presentation. It sounds like what I say every day, most days. Do you think we can actually, one of the big questions is always, why don't they make any neonatal product?
So I actually spent a lot of time the last 2 years working with 3M. I spent a lot of time working with some of the big industry, and they just didn't see the financial gain in making it for our population. So I think it's going to have to be a grassroots thing. So, I don't think that it's not going to happen, Mark. I think it's just going to take some time. I know that I think when we improve the observation and the monitoring based solutions that are non-adhesive based, I think it'll come with that. But I think adhesives made for babies is not a big enough market for them right now.
No, it's hard to, isn't it? Yeah.
Yeah. And so I think
because that's what I get all the time.
Agree. But
Absolutely.
they're also
Yep.
to pay for these products, you're right. It's about how we use them.
Yeah. Thank you so much. Fabulous presentation, Dee.
Thank you, Marg, and thank you so much, Dr. August. It has been a pleasure to listen to you, and thank you for everyone for joining all around the world. Look forward to seeing everybody next week. Thank you very much.
Bye, everybody.
Bye.